Just confirm very quick with our technician, and then I think we are ready to go.
Yeah.
Okay, start. We ready? Hello and welcome everyone to the 5th episode of our bariatric surgery series. My name is Tarek and I'm part of the international sales department at Ezisurg Medical. The first thing I'd like to do is to give special thanks and appreciation to our speakers and the moderator of today's session. It is really a great honor for us to have you, four well-known surgeons, with us here. And considering your great experience and your excellent reputation, only your contribution will guarantee the success of this event. Therefore, I'd like to introduce today's four speakers. First of all, Dr. Safwan Taha from UAE, who will be also the moderator of this event. Dr. Ahmed Al-Masri from Egypt, Dr. Mohammed Al-Sibani from Oman, and Dr. Skrobic from Serbia. I would also like to thank everyone who will join us today. It is a great pleasure to welcome those of you who have been with us in the last 4 episodes, as well as those of you who are new to this event. And for those of you who are new and who don't know us, I would also give a very brief introduction about our company. Ezisurg Medical is one of the national leaders in the development and production of MIS devices. Our product range goes from surgical staplers, surgical instruments, over to endoscopic systems and energy devices. And to support the bariatric education and also to unite against metabolic disorders, we started this webinar series where top surgeons and physicians will have the opportunity to discuss the most recent and most important topics in the bariatric field. Therefore, we wish you all an enjoyable and more important and highly educative event. And now I would like to give the words to the moderator, Safwan Taha.
Thank you very much, Mr. Khouri. It's a great pleasure, really. Again, I echo your statement, thanking Ezisurg Medical for starting those series of bariatric educational scientific activities. I attended the last one, and it was really a very good one. Hopefully, with my esteemed speaker today, we will try to match it, or inshallah, we surpass it. I'm really happy to take part in this event, both as speaker and moderator, and even happier to have a very esteemed team of speakers with me. Colleagues and friends. Dr. Sibani is a friend. We've met several times before, not so much last year because of the corona, but hopefully in the near future. So my speakers are, my colleagues are Dr. Mahmoud Sibani, his head and program director of bariatric surgery in Department of Bariatric and Metabolic Surgery, Armed Forces Hospital in Oman. He is a consultant bariatric surgeon. He's going to talk to us about the long-term results of and outcomes of bariatric surgery. With us also is Dr. Ahmed Al-Masri, consultant bariatric and metabolic surgery in Cairo, Egypt. And he's going to talk about the metabolic outcomes of OAGB, or single anastomosis gastric bypass. I'm sorry, single anastomosis sleeve bypass, the SASI bypass, Aptobi, sorry. And last but not the least, I hope I'm pronouncing the name right, Dr. Orgnejan Skrobic. Is that right?
Yeah, that's right. Thank you.
It's a pleasure to have you, Dr. Skrobic. Dr. Skrobic is vice head of Department of Esophageal Surgery, First Surgical University Hospital, Clinical Center of Serbia. He's going to talk about a way to reduce complications after sleeve gastrectomy, and this is the commonest procedure by far. I'm sure we'll be very happy to listen to that presentation. I'll be the last speaker, and I will present a rather old paper of mine, study of mine. I'm presenting it all because of two things, because I'm following it up with the sequel, hopefully in 3 months. I'm doing the data. That was the first published data of long-term follow-up of sleeve gastrectomy. It's a 5-year follow-up for 700 cases of sleeve gastrectomy. It was, I presented it like 4 years ago, but now, inshallah, before the finish of this year, I'm going to present the 10-year follow-up of the same patients. This is the only large series long-term follow-up for sleeve gastrectomy in the Gulf. I'll be the last speaker. So in order not to waste everybody's time and go to the, to the fruitful part of this meeting, I'll give the screen. We don't give stages anymore. We are giving screens nowadays, right? So the first speaker will be my dear friend, Dr. Mohammed Sibani, consultant and head of the program, the Bariatric program, the Department of Bariatric and Metabolic Surgery, Armed Forces Hospital, Oman. The topic will be long-term results and outcome of bariatric surgery. The screen is yours, Dr. Sibani.
Thank you, Dr.
One thing I'm sorry, I forgot to mention, I'm terribly sorry. The time of the speaker will be like 20 minutes, and we will have 5 minutes afterwards for questions and answers. So I urge my esteemed speakers to stick to the time as much as possible. I'll have to remind you when we go there. And we will leave 5 minutes after the same talk for discussions. I'm sorry for interruptions, Dr. Sibani. The screen now is really yours. Thank you.
Thank you. Thank you, Prof. Safwan, for this introduction. And I would like to thank Ezisurg for this opportunity to present in this CME. I'll share my screen. Sorry, I'm trying to figure.
I think Mr. Tariq should give you the sharing capability.
Tariq.
Now you need to show us the full screen mode, Dr. Sibani.
Sorry for this. I'm trying to.
Dr. Sibani, please press F5. So once you press F5, I think you'll go to the presentation. It's either F5 or the big monitor down at the bottom of the screen, or F5. Simply press F5 on your keyboard.
I'm pressing it, but it doesn't come.
Then, if you go down to the end of the screen, I mean your presentation, your screen, there are like a few icons. One of them is an icon of a full monitor. So if you press on that icon below, it should open. Yeah, that just, it's the icon just close to the bar that increases the percentage of the screen, the sliding bar. There's just close to it, there's a monitor, a picture, a symbol of a monitor. Press on it, and it should take you to the presentation.
Still, I couldn't get.
if you go down your screen, there's a sliding bar. If you're opening the PowerPoint, there's a sliding bar that slides the size of the screen just to inner to it, medial to it, closer to the center of the screen. Just by the slide bar, there's a symbol of a monitor.
Yes, yes.
Just press on it, and then it will open the presentation.
Are you getting it now?
Yes, now we can see it.
You can see it?
Yes.
Okay. Sorry for that delay.
No
Thank you
issues.
for giving me the opportunity again. I'll talk about long-term result and outcome of bariatric surgery. So as we all know, the prevalence of obesity worldwide is increasing, and actually it's projected to be a high in the developed country in the coming futures, where in some area of the developing country, we can see more than 100% increase rate of obesity in the coming decade. Obesity associated with many complications. It's a systemic disease that involves all organs of the body, cardiovascular, hepatobiliary, involving in the metabolic syndrome, and different kind of cancer related to overweight and obesity. The current evidence of result of metabolic and bariatric surgery showed with a good evidence that there's improvement or resolution of type 2 diabetes and other cardiovascular comorbidity. And there is a new data also showing that bariatric surgery might prevent type 2 diabetes, and it had demonstrated safety as other general surgical procedure as well. So a lot of professional medical society now support bariatric surgery, and in fact they recommend it in their guideline. So why we treat obesity? Of course, for weight reduction, and that's very important for the patients, resolution of comorbidity, and improvement of quality of life, and improvement of survival and life expectancy, and many more. Evidence on this is based on high quality, randomized controlled, and level 1 and 2 data. And we have a body of evidence of these studies, and some of them really like a reputable one and published in very reputable journals. Most of them are intermediate or some long-term follow-up on those studies. If we go in the famous Stampede 1 and 5 years paper, which randomize patient to medical therapy versus medical therapy with gastric bypass or sleeve gastrectomy with the endpoint of glycated hemoglobin of less than 6, which showed good control of glycated hemoglobin on follow-up of 5 years in the surgery group. There's a reduction of diabetic medication and insulin intake on those patients as well as reduction in the body mass index of those patients. Mingron also published in New England Journal of Medicine result of follow-up of patients where they randomized to medical therapy versus surgical therapy, and it showed that bariatric surgeries are superior to medical therapy on treatment of type 2 diabetes with adequate control of glycated hemoglobin. The Swedish obese subject is another strong data to support that it's markedly, the bariatric surgery is markedly efficient in prevention of type 2 diabetes. Carlson studies more than 2,000 obese subject, and their counterpart of control match subjects, and followed them up for 15 years. There is significant lower incidence of type 2 diabetes among patients who underwent bariatric surgery comparing to control group with a very good p-value as this figure show. Buchwald also had a systemic review of more than 135,000 patients with overall resolution of diabetes of 87% at a different type of bariatric procedures. So the evidence continue on, and recently we had this study published this year from Italy, where they looked at the efficiency of bariatric procedure with a 10-year follow-up of a single center in a randomized controlled trial. And it showed improvement in systolic blood pressure, cardiovascular risk, and diabetic medication, as well as diabetic remission. And interestingly, it showed that surgical procedure reduce or resolve microvascular and macrovascular complication as well. We can see here the sharp reduction of microvascular complication of diabetes. Regarding the effect of bariatric surgery on cardiovascular risk, studies showed also that reduction in hypertension, diabetes, and dyslipidemia reduce cardiovascular risk. And in this study, it showed that the risk reduction of 10 years coronary artery disease has determined by a Framingham risk score, which is 40% less in a patient who underwent bariatric surgery. So they showed that there is a resolution of diabetes, hypertension, and dyslipidemia, and also 40% reduction, relative risk reduction of cardiovascular risk, which is very significant. How bariatric surgery affects the cardiovascular risk? It's through reduction of atherosclerosis at the level of adipocyte cell, and classical risk of hypertension, diabetes, and dyslipidemia, as well as at the level of endothelium, where it's decreased E selection and B selection, selectin, and systemic inflammatory and exudative stress reduction as well. At a level of myocardial GLP induced vasodilation and decreased inflammation and increased glucose uptake in the myocardium, and it has systemic effect as well to reduce the cardiovascular risk by improving the glucose metabolism and weight reduction. Quality of life, we present our data on quality of life in IFSO Madrid 2019. It's well established that bariatric surgery improved quality of life of patients. So we studied the quality of life by MABI score, where 362 randomly selected patients were followed up for a period of 1 year. So we give them the questionnaire for 3 and 6 and 12 months, and we did our analysis. The questionnaire is 76 points of gastrointestinal symptoms and 28 points on physical function. The results showed that there is improvement in total quality of life scores with good significant p-value at 6 and 9 and 1 year. Also, there is improvement in physical function, emotional function, social function, and medical treatment as well with a significant p-value. This graph showed the improvement in quality of life score for both sleeve gastrectomy and gastric bypass. Another unlooked cause of morbidity or mortality in obese patients is fatty liver and NASH, where we know that a lot of patients come for surgery have that type of liver. So we also present this data in IFSO, long-term outcome of NASH after bariatric surgery. It's well known that it's associated with the metabolic syndrome, and it's linked to insulin resistance. So it's had higher mortality due to cardiovascular and liver-related morbidity. So the spectrum of NASH divert from healthy liver to cirrhotic liver where NASH and NAFLD lie in between. We took our obese patient, we did a fibroscan to assess their CAP score and the score of their fibrosis, then intraoperative wedge liver biopsy were taken, and we assess histologically the liver to score the NAFLD and NASH. This is demographic data for patient. Most of the patient has hypertension, diabetes, obstructive sleep apnea, and osteoarthritis. So we did a fibroscan to get the CAP score and fibrosis level of the liver. And then we scored the histological scoring of the liver biopsies. And this is the results. 52% of our patients are NASH positive. NAFLD score by Kleiner is K3, which is very significant and consistent with the published data. And the correlation with the fibroscan is good. There is no correlation between gender, age, BMI, and fibrosis and NASH. We conclude that NAFLD or NASH is a serious problem associated with morbid obese patient, and diagnosis and follow-up should be done through fibroscan or other modality, and it should be NASH should be considered in guideline to recommend bariatric surgery. So the outcome of bariatric surgery is global, and it's involved different parts of body system, including improvement of metabolic syndrome, cardiovascular risk, and NASH or NAFLD resolution, fatty liver improvement, and improvement of general quality of life. This is from ASMBS data, which showed that bariatric surgery is comparable complication and mortality comparing to the other type of major intra-abdominal surgeries like colectomy, anti-reflux surgery, rectal resection. And length of stay is comparable, and actually utilization of laparoscopy definitely better than other type of surgery. There's a growing consensus favor bariatric surgery, and we can see it in different society recommendations, including American Diabetic Association, Heart Association, Diabetic Federation, and clinical endocrinologist recommendation. We're really happy to see a recommendation to consider or recommend metabolic surgery in the algorithm of treatment of type 2 diabetes, and hopefully we see it in other we see it also in other type of comorbidities like cardiovascular and NASH. I think the future of surgery is the outcome of this bariatric surgery are promising, and we have each one have his own data and global data to support this, and also for patient satisfaction. We're happy to see patient before and after, and the amount of improvement of their health and well as well. Thank you for listening, and I hope we cover long-term outcome of bariatric surgery, and you're welcome to have any discussion in this regard.
Thank you very much, Dr. Mohammed, for the very nice presentation, and of course also for sticking to the time. That was fantastic, doing both jobs so efficiently. We have 5 minutes now for questions, where, as you know, there are two ways of doing that. You can either raise your hand through the screen, through the participants down, or you can send us something through the text messaging, which is also down at the bottom of the screen, of the Zoom screen. There's chatting, and there's the participant. If you open the participants, you will see that there is a raise your hand symbol. So if you have questions, Dr. Muhammad. Okay. So it was actually a very well-informing and very much informing presentation. Everything was clearly laid out. Dr. Muhammad, thank you very much. My next speaker, just like I outlined earlier, is Dr. Ahmed Al-Masri, who is consultant bariatric and metabolic surgeon in Cairo, Egypt. And he's going to talk to us about the metabolic outcomes of SASI, single anastomosis sleeve ileal bypass. Dr. Masri.
Thank you, Dr. Safwan. It's my pleasure to be with you and with all the team. I'll speak today about the long-term result, our long-term result of SASI bypass. So I'll share my screen and I want to thank Ezisurg for giving me this chance. Muhammad, close his screen. Dr. Safwan.
Yeah, I think it's now it's not with Muhammad anymore. It's with Mr. Our host, I think Mr. Tariq, who can give this share screen ability to you. I cannot do that. And once he give it to you, then you can share the screen. Dr. Sibani has no control over on the screen. But Dr. Sibani, you have to. There's up at your screen. There's stop sharing. You have to. I think that's what Dr. Ahmed Masri wanted to tell us. Yes. Now, once you stop sharing, now Dr. Ahmed can share it if Tariq has given him the privilege, which I think he did. Now you can share your screen, Dr. Masri.
Okay.
Thank you.
You can see the screen now?
Yes, we can.
Okay. Today I told you I'll speak about the long term of sleeve ileal bypass. Obesity and type 2 diabetes has become a major public health problem. Medical treatment fails to provide adequate control in a significant number of obese diabetic patients. Bariatric surgery seems to be the most effective treatment of type 2 diabetes. Bariatric procedures can be divided into 3 general categories. As everybody know, restrictive procedures like sleeve and gastric band, malabsorptive like jejunal-ileal bypass, and combined malabsorptive restrictive like Roux-en-Y, MGB, and bipartition. The concept of transit bipartition is modulation of the neuroendocrine control of hunger and satiety, no harm to the digestive function as gastric and pyloric and duodenal function, without exclusion of any part of the small bowel. SASI bypass is a novel metabolic bariatric surgery based on bypass operation and MGB and Santoro operation, in which a sleeve gastrectomy is followed by side-to-side gastroileal anastomosis with no duodenal exclusion. The procedure was developed by Professor Tariq Mahdi. This is our technique. This is a video for our technique of how we do it. As usual, we start by dissection of the greater curvature. We start about 6 centimeters from the pylorus. This is the first reload. Usually good sleeve equal good SASI. We usually reinforce the last 2 reloads with proline 2O, so to decrease the risk of bleeding and risk of leak. This is the opening. Usually the classic to start counting from the ileocecal valve. However, we usually start from the DJ and complete counting all the intestine to the ileocecal valve because we faced 2 times a case of internal hernia. We leave about 3 meters from the ileocecal valve and side to side by either 40 or 35 reload, and it's usually done anterior. We close it by Vicryl 2O. We close it in a single row. This is the passage of the Bouget and the test of methylene blue. So as you see that the dye is passing easily. SASI bypass, its mechanism of action involved in diabetes like restriction of the gastric volume, reduction of the caloric intake, smaller part of the meal empties through the duodenum, so decrease the overstimulation of the proximal gut, rapid entrance of undigested chyme into the ileum, which is the most important, amplifies the nutritive stimulation of distal gut GLP-1 and PYY and other distal gut hormones, reduction of the gastric emptying, which is called functional restriction. Early satiety due to generated hypothalamic satiety sensation. The advantage of this technique is simplified modification of the transit bipartition, less mechanical restriction, so less vomiting, less intragastric pressure, so decrease the risk of leak, no gastric remnant, the antrum is preserved, no mesenteric defect, so less incidence of internal hernia. One anastomosis only may be associated with less anastomotic complication and shorter operative time. Full endoscopic access to the paleo-pancreatic limb, easy reversal of surgery to sleeve, less malabsorption and nutritional deficiency. However, still, there is the problem of gastroesophageal reflux. And as Dr. Tariq said before, that the problem is not the bile in the stomach itself when it comes in the esophagus. The other problem is the marginal ulcer. Our experience, last 1 year, we conducted a prospective study among 50 morbid obese patients treated with SASI bypass between July 1, 2020 and June 30, 2021 at Arab Contractor Hospital, all done by the same surgeon. The age between 32 and 47 with BMI from 39 to 54. Follow-up is done 3, 6, and 1 year post-operative. Patient with previous bariatric procedures and midline laparotomy were excluded from it. Pre-operative evaluation, full history, and the routine lab with abdominal ultrasound to assess the fatty liver. As we can see, the BMI is ranging from 39 to 54. It's average 48.7. The study including 40 female and one female. 80% of the patient diabetic and 40 were hyperlipidemic, and 25 or 50% of them were hypertensive. Our results show that the hemoglobin A1C is reduced from 9.9 to 5.7 after the first year, and the triglycerides reduced from 2.7 to 1.1, with the LDL from 4.9 to 2.2. So the results have demonstrated that SASI bypass is a safe and effective procedure in type 2 diabetes with significant improvement of hemoglobin A1C, lipid profile, and the blood pressure. Percentage of excess weight loss calculated from an ideal BMI of 25 has been excellent. There were 75% at 6 months weight loss and 80% at the first 1 year. There were no intraoperative complication. One post-operative bleeding from the stable line of the stomach. Usually nowadays we protected the stable line with running sutures. No leak has been detected from the gastroileal anastomosis. None of our patients developed diarrhea. One patient had submitted to a reversal operation for excessive weight loss, not for malnutrition. During follow-up year, no case developed malnutrition. However, follow-up of our patient is still short. Most of the revisions of malabsorptive surges fall done after the first year, from the first to second year. No cases in this study had internal hernia. However, after that, we have 2 cases of internal hernia, so we start closing the Peterson space. Our conclusion is that SASI bypass is a promising operation, very easy to perform with an easy learning curve. The SASI is an effective bariatric and metabolic surgery that achieves satisfactory weight loss and improvement of medical comorbidities, including type 2 diabetes, hyperlipidemia, with a low complication rate. However, more number of cases and longer duration follow-up still needed. Thank you.
Thank you very much, Dr. Ahmed, for your presentation, and again for sticking to the time frame. Really appreciate that. I'd like to kick off with questions with a comment and a question, and we will take give the time for everybody to put their questions. I have to have a little disagreement with your classification of bariatric procedures. I don't know. I'm one of a group of surgeons who believe that sleeve, not because we think that, because of the data, we believe that the effects of sleeve are probably only to a little part caused by its restrictive effect. Much more important is the hormonal effect it plays on a lot of change hormones. So we hardly call it a restrictive procedure anymore. It's partly restrictive, definitely. It's not metabolic, surely, but the hormonal changes that happen with it are more important than the reduced amount of food that they take. That's as a comment. My question is about the site of your SASI anastomosis. You said that it's 3 meters from the ileocecal valve, and that you, of course, measure the whole bowel. So you go 3 meters. My question is, you go 3 meters irrespective of the bowel length. You know, there are a certain percentage of patients where the bowel is relatively shorter than the standard. It's not very short, but shorter than the standard. So the length of the bowel has no bearing to your decision about how long you exclude.
Okay, thank you for your comment. First, the sleeve, I'm convinced that the sleeve also have a hormonal effect. Nowadays, we see that a lot of patients, even with diabetics, when undergoing sleeve gastrectomy only, we find that the hemoglobin A1C is reduced, and so I'm believing that it's have a hormonal or strong hormonal effect also. Regarding our technique of SASI, when we started doing it, we started as Dr. Tariq said to let 2.5 from the ileocecal valve, and actually we find it's a little bit okay, two or three cases of malabsorption. This is since like 4 years, I think. So we start counting all the intestine, and to make sure that we have 3 meters, 3 meters of the common channel. Regardless the whole bowel length, it may be we found we exclude 2 meter, 2.5 from the DG. Even we may exclude the 3.5 and save only 3 meter, unless the patient is doing the surgery mainly for the effect of diabetes. So we are convinced, as Professor Santoro said, that the main hormonal effect from coming the food to the alkyne to the ileum and not the jejunum, and this is the difference between it and between the NGP as an effect of the power of reduction of diabetes. So we try to make sure that we are in the ileum 3, maybe 3.5, because if you find the intestine, whole dense intestine is about 8 or 9 meters, so you can exclude it. So we can remnant common channel is 3.5. This may be, or even 4, but you have to make sure that you are in the ileum to have the good result of the test.
Thank you very much. Any questions? I am not getting anything in the text. Yes, Dr. Muhammad, please. Dr. Muhammad, you just unmute yourself or press the space bar. Yeah.
Thank you, Dr. Ahmed, for this presentation. I have a question. How you can ensure that food will pass through the alimentary tract rather going to the duodenum? Is there specific things you do during the anastomosis to help this, or you leave it to chance or chance whether it goes to the normal pathway or the new anastomosis? It's obvious that
Okay, thank you for your comment. Let's speak about the power of the operation itself is not by to divide the food is in equal portions in the two pathways. The main effect or the main power of the surgery is even a small part of food coming to the ileum. It will keep the functional or the hormonal effect of the surgery itself. So if you do the bypass by reload 60 millimeter, it will actually act as or work as a malabsorptive or a bypass only. If you do it with the 30 millimeter, it will be a little bit smaller because when we pass with the endoscopy, we found that the 30 millimeter is the opening after 1 year. It's about 1.5 or 1.2. So we found it that 40 millimeter to 45 is enough. When you use the dye or inject the dye or try the barium meal, you will find that it passes easily in both ways. When we decide that it's working as a bypass or as a sleeve, we find that there is no single case of malabsorption. So you find, as you know, if you do MGB, you find the hypoalbuminemic in some patients. You will find it. However, in SASI, you will not find it. It's very rare to find the case of hypoalbuminemic. Despite all the patients is not tolerating the protein very well as usual. But we find that the long-term result so far, no case of malnutrition. So the size of the reload, I think it's the main cornerstone of detecting whether it will act as a bypass or as a sleeve.
Yeah, I think the result of metabolic result of the procedure will be great. But what about patient weight reduction? And do you have cases that they fail to reduce weight? Actually, I have a patient who have done SASI outside, and the complaint, the patient came with me that her weight is not reducing, although her comorbidity resolved. And what I did, I just convert her to one anastomosis gastric bypass or mini bypass, and she was very happy with that.
As you know that every procedure has its failure rate and failure to achieve the goal, the ideal weight or the goal weight that she want or he want. So I think it's mainly we find some cases actually, especially in the redo cases after band, let's say, failed to achieve the weight, and we converted it to bypass. But actually, we found the same problem with MGB and failed to get the ideal weight and change it into SASI. I know it's very difficult and not easy to do it, but with a good weight loss. So I think that the failure of weight loss mainly maybe the problem of habits, as you know, that it's not only about the surgery itself. Maybe some cases which failed to achieve the weight or malnutrition because we had 3 or 4 cases done out of our center with malabsorption. So when we find that it's only 2 or 2.5 because some surgeons count a lot of the intestine. So actually, we faced some cases of failure, which was to be honest. But I think it's maybe affected the surgery itself, like other surgery, like when you fail with the sleeve or the MGP, or Ron-Y, failure, weight regain. I think it's this era we are doing repair or for the Ron-Y bypass patients after 10 years, with they all started to gain weight. So long-term result will be needed for SASI for to make sure that it will preserve it.
Thank you, Dr. Shibani and Dr. Masri. Dr. Skorbich, you wanted to ask the last question?
It was the similar question. It was the similar question as the Dr. Shibani asked. So it was how the failure rate for the weight loss. That
Yeah,
was
bariatric surgeons generally have the same concerns, right?
Yeah.
So since I have no more questions in the messages pane, we go for our third speaker, Dr. Skorbich. He is vice head of the Department of Esophagogastric Surgery, First Surgical University Hospital Clinical Center of Serbia, and he's going to talk to us about a way to reduce complications after sleeve gastrectomy. Screen is yours, Dr. Skorbich.
Thank you, Mr. Chairman. Yeah. Okay.
Absolutely.
I hope you can see me now.
Yes,
well?
you can. Thank you.
Okay. First of all, I would like to thank the company, the Ezisurg company, for inviting me to give this talk, and for you, Chairman, esteemed Chairman. I'm glad to be in a company of esteemed bariatric surgeons. Myself, I'm predominantly esophageal surgeon, and 10 years ago we started with a dedicated team for bariatric surgery in our hospital, and started as a part of our work doing a lot of esophageal and gastric surgery. We started with the bariatric surgery. So I will try to make my presentation as a way to reduce complications after sleeve gastrectomy. So these are now the common facts. What once started as a bridge procedure, it became adopted as a standalone weight loss procedure. And not only that, it is now the most commonly performed bariatric procedure, in particular, I think now in the majority of the countries in the world. And it has similar effectiveness in weight resolution and resolution of comorbidities as the Roux-en-Y. What is maybe a little bit contradictory, we know it's technically more simple and it's shorter operative time than it is with the Roux-en-Y, but we have similar almost mortality, morbidity rates and complication rates, which are sometimes even more often than in Roux-en-Y. So why is that? When we perform the sleeve gastrectomy, we have specific pattern that we create, and that is due to creating the high pressure system. You know, with basal pressure in the normal stomach before resection is 18 to 19 millimeters of mercury. But when we resect it with a saline, it goes up with 45 millimeters of mercury in sleeve. So I think almost all the complications in sleeve gastrectomy, the leaks, the stenosis and the twisting and the staple line bleeding can be in much attributed to this specific pattern, and that is the increased intergastric pressure. So the most fearsome, and which I'm going to try to talk the most complication, is a staple line leak. This is one case that we treated that finished up with a total gastrectomy. Most fearsome complication, we know the incidence is about 1.1 till 5.3, and the average is around 2 to 2.2%. It is very difficult to treat. Almost all the time it's going to be a monthly job. So you have high morbidity and mortality rates, And if you talk about the pathogenesis, these are the ischemic and mechanical causes after the sleeve gastrectomies that are included in the leak pathogenesis. So the mechanical is going to happen in the first 2 days. It's an early leak, and we think it's and the literature data also show it's also indicating that it's stapler misfiring or direct tissue injury. And we know that we are working with a stapler. We have those tissue creep, stress relaxation, and shear stress phenomena, which are all time dependent. And if we follow the procedure as it should be, to take your time with the stapler and to let the tissue adapt, we can minimize the damage that the stapler is doing to the stomach. The second is ischemic, and it's mostly will occur on 5th and 6th postoperative day. The angle of kiss is always a predominant location in this region, and these are the data that I could find that are really related to this ischemic, and these are inadequate dissection. There's a staple line hematoma, and of course the high pressure system. So this is by the literature and the expert consensus guidelines. These are surgical steps which we can do to try to minimize the staple line leakage. So it is a meticulous dissection and adequate gastric mobilization. So choosing the proper stapler cartridge. We have to think about the distance from the pylorus, to avoid the incisura angularis, and to think about the bougie size, distance from the angle of kiss, and of course the traction during the stapling. So the first steps which is adopted at this 5th International Consensus Conference and the current status for sleeve is adequate gastric mobilization. So these are the steps which are advocated and should be done. So taking down the short gastric vessels, completely mobilize the fundus, full exposure of the left crus, fix the hiatal hernia if it's present, and dissect the greater curve up to 4 centimeters to the pylorus. So this is the video now. I will short it a little bit to preserve the time. So we started almost always across the incisura angularis, and then we try to dissect the hiatus as much as possible. In these cases, we always perform the upper GI endoscopy in our patients. I don't know if it's a common practice in your hospital. So this patient had a small hiatal hernia and erosive esophagitis, so we decided to fix the hiatal hernia as well. This, I think, very important step, and as I saw it in a lot of general surgeons going into the bariatric surgery, this can be a very tricky part to dissect the fundus in a proper way and completely. So I think it's obligatory. You see to have a good exposure of the left crus, and you see the fundus is here intrahiatally, and you have to dissect it properly and well. So this patient, as she had a hiatal hernia, we decided also to do the fixing of the hiatus to dissect the esophagus completely. And after getting 5 centimeters of intra-abdominal esophagus, or 3 without tension free, we did the hiatal hernia repair. We don't use meshes in these cases because we are afraid of migrating the mesh into the sleeve or the esophagus, although we use them sometimes in a simple hiatal hernia cases. So after fixing the hiatus, I think what is one of the very important part is to completely dissect the fed pad and to get a clear view on the angle of kiss. So by finish the mobilization, we have to, of course, make the choice for our stapler cartridge. And this is a very interesting study showing the average stomach wall thickness in the males and females, in the antrum, in the mid-body, and the fundus. Interestingly, of course, what we all know that in the antrum and mid-body has average thicker wall, and in the fundus it's less thicker. women tend to have equal thickness of the stomach wall in the antrum and in the mid-body. So the most common practice, as we know, is to start with a higher stapler size and finish the fundus with a lower staple size. Although by the consensus guidelines, it is not appropriate to use staples with a close height less than a blue load at any part of the sleeve gastrectomy, and it was 81% of the panelists that agree with this. Migratory crotch staple, of course, the phenomenon which is in the literature very, very common, and it should be avoided, of course. So these are the common related damage. This is taken from Baker's Science of Stapling and Leaks. And you see the first one is under thighs cartilage, and the second, the migratory crotch stapler. After that, the distance from the pylorus, which was contributed, and some people started with the 1 centimeter, 2 centimeter. It was proposed to 6. And now what was recommended as the average is 4 centimeters by the last expert consensus, which was published. We have that nice study comparing randomized trial, comparing the groups of sleeve gastrectomy 2 versus 6 centimeter from the pylorus. It was a little bit higher incidence of leaks in a group of 2 centimeters group, and that it had negative impact on gastric emptying, although there was a potential great weight loss in a group of patients that had antral resection. So this is the first stapler in this video, and what is recommended to be very important is that it's parallel to the laser curve. I deliberately stopped the video now. So you should, with this one, try to avoid the incisura angularis as much as you can. The next thing which we have to take care about is the bougie size. It used to be recommended 32, but according to the last data, as the smaller the bougie size and the tighter the sleeve, the higher the incidence of the leaks is. And it was adopted by the majority of the experts. Recommended is 36 to 37. We use the 40 French bougie. And what I think is also the very important step is a step-up introduction with a second stapler. So with a second stapler in position for firing, then you introduce the bougie. And this is the short video showing that. So the second stapler is in position, and then after that, you go with a bougie and try to avoid the incisura angularis as seen in here. And now the distance from the angle of kiss, it should be around 1 to 2 centimeters. Again, quote the expert consensus guidelines. Of course, you have to avoid the residual fundus, to carefully identify the esophagus and take down, as I showed earlier, the fat pad. There was an interesting study with a 0% of leakage showing that patients, in all the patients, they did dissection of the esophagus and hyatoplasty. And that was a rather large series of patients with a zero leak. Maybe it can be attributed that after you do the fixation of the hiatus and complete dissection of the esophagus, then you have always a clean view on the angle of kiss and the last stapler firing. So we're finishing with a stapling down the corpus and the fundus, and what I talked earlier. You have to respect the tissue and go slowly and easy with a firing. We leave it for 15 seconds, maybe even more, and go slowly when we firing our staplers. Last stapler, you can see in here, it's around 1.5 centimeters from the angle of kiss, which we have a clear view. I think this is the most important part of the sleeve, and in a way we try when we are trying to reduce our complication rates. So the most controversial question is reinforcement of the stapler line, and this was a good study published in 2020, and they compared 5 groups of reinforcement versus no stapler line reinforcement. And you can see in the oversuturing and absorbable polymer membrane, they have the best outcomes. And it was covered almost over 40,000 patients from a high volume centers. So the best results were obtained by IPM, and oversewing alone had the tendency to better the results than no stapler line reinforcement. So this is what we always do. We reinforced the stapler line using PDS, or sometimes, like in this case, we used 2-O-proline, and the bougie is still inside, so we avoid to reduce our sleeve too much by doing this. And I think that after we started using the bougie of 40 French, we have no problems with the stenosis or kinking of our sleeve. So basically what we do it in a running fashion, completely with the one single stitch, and we use the same stapler line to reinforce. I'll show you and to try to fix the sleeved stomach for the omentum. I'll reduce the video. So this is the way we fix it, on 3 to 4 spots, sometimes even more. So at the end, as a conclusion, these are general recommendations now coming from the literature and partly from our own experience. So it's important to stay away from the incisura angularis to prevent strictures that can cause even higher pressure in the proximal stomach, and to be responsible for the later leak. It's important to take down the short gastric vessels and completely mobilize the fundus. It is acceptable to buttress the staple line, although this is something we have to talk about. There are no clear literature data. And what is now commonly accepted, the smaller the bougie size and the tighter the sleeve, the higher the incidence of leaks. Thank you for your time.
Thank you very much, Dr. Skorbich, for the very nice outlay of the do's and don'ts for sleeve gastrectomy. I would agree with almost everything apart from oversewing because of the conflicting data about that. I actually presented a talk at EFSO and IBC about with international data that, of course, I mean, there are pros and cons. That shows, the way I see it, that it doesn't add anything. It might actually add something which is not wanted. But then there are other data that says it does. For leak, for bleeding, it definitely is a plus. For leak, actually, the data doesn't really support that very much. Other than that, I greatly or strongly support everything else that you said, and thank you very much for highlighting it. Questions? All right, so if we have no questions, then I'll be presenting the last talk, and my talk will be about, as I told you, it's a rather old study, but I'm presenting it just to, because it's the only study in the area, in my region, with the prospective follow-up of 700 sleeve cases over 5 years for the outcome, and inshallah in a few months we'll present the 10-year follow-up of the same patients. So I'll just share my screen. Let me share screen. Where is my screen? This is my screen. I hope that you can see it. Is it okay?
Yeah.
Great. So I'm 1/4 OEGB, 5% through renal gastric bypasses. I do renal gastric bypasses when the bypass is indicated only with confirmed reflux, otherwise it's OEGB. and 3 others like removal of gastric bands or revisions, putting very few gastric bands, some other procedures. So our hospital started doing bariatric surgery. It's Mediclinic Hospital. My hospital is called Airports Road in Abu Dhabi. We started doing bariatric surgery late 2008, early 2009. And initially, I mean, we do everything. I showed you what we do now. And the criteria of selection and the multidisciplinary pre-op management and assessment. I follow the SMBS guidelines. We have a dedicated team of in-house consultants to do everything. You know, the dietitians, psychologists, cardiologists, pulmonologists, you name it, we have them all. The sample size for this study was 715 cases. All the operations were done by myself. And the technique started, and I mean, in 2009, I mean, all sleeve bariatric surgeons know that the technique changed a bit from 2009, 2012. After that, we stressed on 2 things that actually Dr. Skorbich already did stress on them. The most important 2 things that we stress on now, that you have to be really very careful when it comes to the incisura. You need not to go there too close because of the high pressure tube that you'll create when you make a stenosis here. And of course, the leak rate significantly improved when we changed from going flush with the GE junction, the esophagus, to around 1 centimeter from the EG junction. Thank you, Dr. Skorbich, for clarifying that very clearly. This is one of my very early cases, I think 2009, of sleeves. I either buttress or do nothing at all. So, and again, Dr. Skorbich talked about that nicely. Why do we need to, I mean, what's the importance of buttressing or adding support to the staple line? So how did we do the study? So we had random sampling. By random sampling, actually, choosing the patients, because we didn't want to put specific BMIs or specific criteria or specific characteristic. We wanted to do a random sampling. So the random sampling actually in our case was every other patient. So we decided from tomorrow, the first patient who comes will be included, the second will not, the third, and so on, irrespective of the criteria. So it's randomized. And we had 6 cohorts, for 6 years, 2009, 2010, 11, 12, 14, 13, 14. And the issue here, the number of patients fluctuated because our practice is mostly, it's not mostly, it's by far insurance dependent for the local patients. So we had a couple of years here, 2010 and I think 2012, where the insurance criteria were toughened and the number decreased. And you see that affected the data a bit, but it didn't affect the overall data and the outcome. So we collected the data and for analysis, BMI, diabetes mellitus, lipid profile, and uric acid status on admission. Diabetes mellitus, I didn't write it here. Diabetes mellitus was defined as a hemoglobin A1C of 6.1 or more. So 6 or more. And that was taken as diabetes. 5.9 or not was not included. So we did the BMI and percentage weight loss, collected and analyzed for the cohorts, and just like you see here. So for those, the criteria we did were BMI and excess weight loss at 2 years, whenever feasible. BMI excess weight loss at 5 years, whenever feasible. At 3-6 months, and last post-operative follow-up visit, which is post-op visit at least 1 year from the date of operation, at least. So it's clear for 2009, we managed to get all the data, but for the following year, we didn't get 5 years, we got 4 years and 3 years and so on. But it was representative of the pattern, but all the cohorts, we managed to get the 3-6 months, and for 5 of them, we managed to get the last post-operative follow-up visit. The presenting profile was the average age was 33.8 years, quite young population, which is typical of the Emirati population. our patients, I mean, in this study, there were 95% locals, Emiratis. The average BMI, as you can see, is high. It's 47.96, which is roughly 48. And 40% were diabetic, very much expected of the demography in the Emirates. 31 had hyperuricemia, and 55.5 were hyperlipidemic. Well, the nationality was predominantly Emirati because I told you it's insurance based and is covered by insurance for the locals only. And there's no real difference between male and female distribution with the groups. And this is the average BMI of patients on admission during the cohort. So the 2009 and 2014, it ranged between 45.8 to 49, depending on the year of admission. And my explanation for this decline, which is actually, I believe it will be still lower here after 10 years on presentation, is that people started believing in bariatric surgery. We had difficult time convincing people that to go for surgery, and their definition of obesity for a lot of Arabs, especially the middle age and old people, obesity is more or less a sign of good health. It's not a sign of bad health. Probably it comes because of, in the 20s or 30s or 40s, a lot of people, I mean, the socioeconomic status of the Arab countries was not as good as lavish as it is now. And food was not really very common, very commonly available for everybody. So it's changing now. And as you see, 2009, it declined from 49 to 44.8 in 2014. So this is the weight loss of the 2009 group, and you can see at 2 years, and that's excess weight loss, of course. At 2 years, we were like at 28% excess weight loss, and at 5 years, it was like 47% weight loss, excess weight loss, and which is really, if you compare it to international literature at 5 years, it's a very good outcome compared to the international literature. For the 2010 cohort, and as you can see here, at 2 years post-surgery, on admission, the BMI was 42. At 2 years, it was 35. And that was a significant drop of BMI following sleeve gastrectomy in the same population. And that goes for the same, I mean, that's BMI, that's excess weight loss. And the excess weight loss here in 2 years was 46%. Again, it's a very good number for sleeve gastrectomy compared to international literature, because most people do reach 46% or probably a bit higher in the first year, but maintaining that over a long time is actually probably more important than achieving it. That's the cohort study of the 2011, and here I think this is more representative of than the 2012 that you see shortly, because here we had a good number. The insurance criteria was still very more or less generous there, like the international literature, and we had a larger number of patients here. And you can see the drop in 2 years in the 2011 group from 46 BMI. In 2 years, they went to 30, which is really an impressive decline in weight loss, which is reflected here by percentage in excess weight loss. It was 46 in 2 years for the 2010 cohort, but here it was 73% for 2011, and because of the more representative number of samples. The 2012 is more or less the same thing. It's from 48 to 31, again 69% excess weight loss, following the same pattern of 2011. And if you look at the profile summary of all patients pre and post surgery, and that's their BMI at admission, and that's their BMI at 2 years, which we managed to get until the fourth cohort, which was the 2014 year. And you can see it's consistently going from 49 here to 35 or 6, 35, and again here is going to 31. So from almost 50. So at 2 years, it's still maintaining a very efficient weight loss, the drop in BMI. And the first cohort, of course, 2009, we managed to get the 5-year result. And if you can see again, from 49, it was 35 at 2 year, it was still 35 at 5 year. A very encouraging result and a very strong result for sleeve gastrectomy. That's just another bar diagram of the same result. So this is one diagram for all the cohorts. When you combine them, the 6 cohorts, when you combine them at 2 years, the BMI, the cumulative weight loss, it was like 30%, and then for the cohort 1, just 48%, 46%, 73, just I showed you in 11 and 12, 73% and 69% at 2 years, which is really, really, really a good result. The same thing here, it's a bar diagram. And that's the figure with diabetes. This is the drop in the figure here. It was because of the drop in the cases in the second cohort, 2010, I told you about. So very few cases. They were mostly non-diabetic, and that affected the profile. But the rest of the curve is more or less similar. So on admission, the cohort 1, we had 37% diabetics, and at 1 year post-off, they were 12.5. This is, I told you, we had a flow in this. I didn't want to, play with it, but those are, I don't know what's happened here. There was a mistake in collecting the data, but the others are very consistent. So 35%, the third cohort, 2011, and around less than 20% still after 1 year, 41%, around 11% in 1 year. So the drop is very high. It's always like only less than 1/3 remaining diabetic after 2 years. And as I told you, our cutoff line was 6 for the hemoglobin A1C. The same thing applies for the 5th cohort. Another bar diagram presentation. We'll always have problems with the 2010 year, but then this is the hyperlipidemia. And if you look at the numbers again, it's roughly just a little bit more than 30%, much less than 30%, and around 35%. There was significant drop in hyperlipidemia in 1 year, and I'm sure that you all have noticed that the most difficult one to metabolic condition to control probably is hyperlipidemia, compared to also probably to hypertension. You can't really compare them to the magical effect on diabetes, but still it's very effective even on hyperlipidemia. And the same thing applies for hyperuricemia. It's a very serious drop in hyperuricemia in 1 year. And all throughout all cohorts significantly dropped because of small sample, and its percentage here they all get cured. By here it's like by more than more than 75% drop here, more than 50% drop here. It was very effective even in hyperuricemia. So you can see that was really effective mostly in diabetes, but then second in hyperuricemia, and less so for hyperlipidemia, thirdly for hypertension. We had 6 leaks out of 850 cases. Then, we changed our stapling system to something better, and we haven't had a leak for 7 years now after that study. But we had 6 leaks out of 850, that's 0.7%, well within the international numbers. 2 of them were redos and 2 were in the first 30 patients. Did that anything have to do to the old technique that we talked about? Probably an hour in caesura, a staple line very close to the esophagus, I don't know, experience. Well, I do believe that, unlike what most people say, that there is no learning curve in sleeve, I believe there is a learning curve in sleeve, and I believe after a good number of sleeves, your numbers tend to get better, at least mine did. We had 5 bleeding out of those 850 at 0.6%. 3 of them we had to go in again and to drain it, and 2 of them they were managed conservatively. You had 1 collection, a very tiny collection, patients who presented with mild fever 2 months following sleeve, and everybody said it was a leak. When I went in, it was a very localized collection at the GE junction. In my own conviction, probably it was a small subclinical leak that was contained and then became infected and turned into an abscess. So our population is very young in the Emirates with relatively high BMI. The mean was 48, as you saw. The procedure was very safe, as it's now safe worldwide. There's a significant excess weight loss, definitely at 2 years in all cohorts, and even in the 1 cohort that managed to do 5 years, there was significant excess weight loss and resolution of comorbidities. That resulted in increase in acceptance, and I showed you the number of presenting BMI was much lower 6 years down the line after we started performing sleeve gastrectomies in Abu Dhabi. Thank you very much.
Thank you.
So I'm open for questions. Yes, please, Dr. Skorbich.
You have congrats for a very nice presentation and a great work.
Thank you.
Great results as well. Since you have such a long experience and a big volume of cases, how about the reflux after sleeve? How many cases did you see, not of the reflux that you diagnosed prior to sleeve, but the reflux after sleeve in the patients did not have symptoms of reflux disease before surgery?
Thank you very much for a very important question that I think is of prime importance in choosing patients for bariatric procedures. In my humble opinion, one of the, at least in my country, in my area, one of the main reasons of complications and failures is the improper choice of operation from the first site. For me, since day one, every patient who have even the a problem with the dyspepsia, as long as they take some sort of medication for dyspepsia more often than anybody should, they will go for endoscopy. And if they have anything more than stage 1, stage 2, 3, 4 reflux, I'm not doing sleeve for them. Yeah. Stage 2, I ponder it. I might do OIGB, might not, depending on a pH study when we do it. But for 3 and 4, I always go to Roux-en-Y gastric bypass. So I think that played, Dr. Skorbich, I think that played an important role in the very low, very low incidence of reflux I have in my sleeves, because they are well scrutinized. I mean, the patients who undergo sleeve in my center are like, I mean, probably I should do a study about that with other parameters, but I'm sure they are at least 95% dyspepsia free totally. Otherwise, I don't do sleeve. So yes, I've, out of around 2,400 sleeves, I mean, the ones that came back to me, I might have lost some patients to other doctors, I don't know. The ones that I had to revise into Roux-en-Y gastric bypass are 2. Yeah, my patients. Of course, I've done quite a good number of revisions, but my patients, I might lost a lot, but still it's a low number. but because, as I told you, I'm very serious with not operating on patients with moderate to severe dyspepsia. I mean, and I don't do that on my own judgment. I scope them. If a patient says, yes, I take Nexium or whatever, like once a week, twice a week, something, even with that low frequency, I scope them. And if I have a suspicion, I do a pH study. And if the pH study is positive, they are not getting sleeves.
Yeah.
But that's a very important question. Thank you. I think we should be very important. As a matter of fact, the good thing, since you raised it, Dr. Skorbich, one of the those 5-6% who have very mild dyspepsia and the pH is fine, most of them did very well after the procedure. I couldn't explain that. Of course, one of the explanations that are said in the literature is that when you remove most of the stomach, then the acid secreting mass will decrease, and that might help. And probably the other thing that might help is I do put the 36 French calibration tube, but I make it a wide sleeve. I mean, I would end up probably with, like yourself, with a 40 French calibration, but I don't suture. So it's a rather loose sleeve. It's a rather loose sleeve, rather loose, and with the scrutiny, I'm getting really very good results. But thanks for asking.
Thank you. Thank you.
Dr. Safwan,
Yep.
how far you stay from the pylorus?
4 centimeters.
4 centimeters.
Yep.
So you really don't go really close.
No, as Dr. Skorbich outlined, and I mean, I've seen a couple of, I had a couple of sleeves referred to me with like very close suturing to the pylorus, and the explanation that's in the literature for that is when you go closer, the pyloric muscles are thicker than the antrum. So even if you use the black load, it might not show initially, but it will leak later on because of the loose, suture stapling. So that's the explanation. And again, just like Dr. Skorbich outlined, there's definitely in the literature, it's not huge, but statistically significant little higher leak rate with 2 centimeters to the pylorus. 6 centimeters is still accepted in the literature, but they say there's no solid data, but they say that you get more weight regain on the long term. But 4 to 6, generally, so far there's no solid data of a difference in recurrence rate on the long term. But when you go 4 centimeters, the rate of loss is quicker, and that's documented. So it's very emotional for Arabs. You know, patients come, I didn't lose much weight. My neighbor lost 40 kilograms and I lost 25. Come on, your neighbor is 180 and you're 120. You cannot compare. So what I do is, Mohammed, is I always educate my patients before surgery that when you talk about your weight loss later, we are going to talk about a percentage, not about an absolute number. And I spend like 5 minutes to explain what's the percentage for them in lay terms and something that they can understand. And that really removed a big headache from me that I had in the beginning, in the first 4 years of my practice, when I was not giving attention to that. You know, the Arab mentality, they're very emotional. My neighbor lost 25 kilograms. I lost 30. This is not a good operation. And then when I do the percentage, so they discover that they did better. So yeah, I do 4 centimeters routinely. But one thing I do, probably, I don't know what, you won't agree. I calibrate even the first stapler. I mean, that's me. I'm sorry, but I do that. The first leak I had was because of a narrow incisura, and it was a nightmare. I don't want it to happen again. So that was my sleeve number 15 or 16. So following that, from the second year, I started calibrating even the first staple. It might be a bit too much, but it gave me a peace of mind.
Actually, I do the same. I push the calibration tube all the way down, then I start stapling. And I'm happy with this technique. And as you mentioned, and Dr. Skorbich mentioned, it's not a matter of the size only, because you can choose 36 and make it a little bit loose, or you can do 40 and, you know,
You
stay
can make it
close
too
to
tight.
the calibration tube. So it's a matter of, you know, and I think there is a data controversy in the data where the loss of weight is relative to the bougie size or not. I don't know. What do you think about it?
Yeah, there is. If the weight loss doesn't change between 36 and 40 French bougies, that's the data. But if you go below 30 to 32 and or less, it will not give you more weight loss, but it will give you definitely higher leak rate. So the safest for leak and the best for weight loss is anything between 36 and 40. That's data documented.
What about did you faced with the twist of the sleeves? And
Yeah.
what's your approach to that?
Yeah, I think one good thing that I love about buttressing the sleeve is that I never had a twist, not a single one with buttressing. And out of those 2,400, I was working with the army they're sending the patients for me and they were paying per actuals, not insurance. So for 4 years, I was doing 98% step buttressing. So it's around like 1,200 cases or 1,400 cases. And I didn't get a single twist with buttressing because what happens is with buttressing, it will act as a splint to the staple line. It's not my intention to popularize it, but what I like is the seam guard. And it's stiffer a bit. And it gives you a guideline. So when you go a bit anterior or posterior, it will show there. Yeah, guy, Safwan, take care, you're going down or up. And then you correct it completely. So I love it with the stapling. I had my own, I had 6 twists on my own. The 2 I didn't discover initially. I discovered them on Barium next morning. And the other 4, I got the lesson. The other 4, I noticed them intra-op when I don't do omental suturing routinely, but when I notice a twist, I do omental suturing, but I don't do it in selected places. Dr. Skorbich, I did that once and I had to go again because when I did it on 4 places, when the patients stand up, it's a very heavy omentum and it pulls the stomach in only 4 different spaces. On my bad luck for that patient, the twist part itself, the center of the eye of the hurricane was not on one of those stitches. So when I stitched it, I stitched completely. Just like when Dr. Corbett showed us how he strengthens the suture line, I do it taking the omentum and those twists, and it's excellent. And I had 7. The 7th one that was 8 months ago, a year ago, and we started doing something else. I discovered it next morning. It was very subtle. It was not in the OR, but in the barium, it was clear. I didn't like it. Probably others might have passed it, but I didn't like it. So we were thinking of using stents for twists. But the problem with stents, as everybody knows, when you were using them for leaks, the sleeve stents, they go into the lower esophagus and they give your patients a notorious time. Patients don't really like it. And I think this is one of the reasons why most bariatric surgeons, at least all I know, they have abandoned putting stents for leaks because patients will not take them. I have an excellent gastroenterologist, a Norwegian, and he's one of the pioneers in the Gulf. He has like 600 published papers. His name is everywhere. And he said, Safwan, why don't we use the esophageal stents? They are shorter. They are not too wide. They will not push the stomach strongly, suture a staple line. They will not cause ischemia. And they snap into position like that. It's a Japanese mark. I forgot the name. And we put it, and it was fantastic. Fantastic. We removed it 2 weeks later, and everything went well. And I actually told a few friends about it, and they referred me 6 cases since then. And we put for them 6 stents, and they did dramatically well. So I'm preparing a paper now. And now I have the total of 14 cases. and I'm going to present it.
Chronic, Dr. Safwan, if it's chronic, it's not in early stage. Like someone after a year come with vomiting and you discover that he's having a twist. Will the stent work?
Ruin
Because
yeah. I had 3
it
chronic.
might work early, but not in later.
Yeah, it worked actually for a patient from Syria. She was 2 months, and my gastroenterologist endoscoped her, and he said she might stand a chance than doing a Roux-en-Y. And we put a stent for 10 days. She didn't like it more, and she did very well. That's the only one. But I had 3 cases between 8 months and 1 year. There was no way. I mean, just like you said, structure now is like stainless steel solid. For those, I believe I do Roux-en-Y straight away.
Gastroplasty, will you try gastroplasty?
Gastroplasty is a very, it's much easier said than done. I've seen Hempins doing gastroplasties, and it's Hempins with all expertise, and it's really, and he had quite a few punctures and quite a few of them, because you want to slice the serosa and leave the mucosa in a very unhealthy tissue that been there for a year. And eventually, what's the point to save a sleeve that is not working well? I don't know. I mean,
sometimes patients are resisting bypass. That's what I have.
Dr. Mohammed, thank you for raising another issue. I don't really. I hope I'm still ethical. I don't really yield into patients if they insist on something that is not supported by the literature, even if it's there. I mean, in any science there are options, but there's a very strong option and there's a weak option that you might go to that, blah 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 blah. But if you have the expertise, just like yourself, you have the center, you have the supporting services like everybody here, and you have the expertise, you do a bypass, and it's a peace of mind for yourself and the patient. Because I mean, even a gastroplasty, it will not heal completely as wide as you've done it. It might stenosis again. I don't know. It might might leak.
Yeah, it's sometimes just difficult to convince patient to convert to bypass. Whatever you tell them, do anything, but not bypass. We have some people who come occupied.
I agree. I tell them, then it didn't happen to me, but then I tell them, please go find someone who is an expert in gastroplasty, because I'm not an expert in gastroplasty, and if I cannot help you, I don't want to harm you. I mean, it's something like that. I have patients who come with a BMI of 29 and she wants a sleeve and she begs and she want to pay double the amount, and eventually she goes to one of the doctors who don't care about Hippocrates and everybody else, and they do that for the money. But I can understand your point. Sometimes it's indicated. Yes, I mean, it's not indicated, it's an option, but I haven't done a single gastroplasty. So doing a gastroplasty for a difficult case for the first time without assistance from an expert in it, or being trained by an expert somewhere sometime, I don't think, for me, that's not an option. I found it, I don't know, at least in our patient, most the patients that I talked to, by far, who didn't like what I want them to do first, by far, they accepted it after like 10, 20 minutes of discussions, generally. But I get the point. Sometimes you get this stubborn patient who don't accept anything. I apologize for them. I said, I'm sorry, you can find another person. I agree. Well, I'm sorry, probably we took a lot of time from the audience, but it was really a nice discussion. Thank you, gentlemen. Mr. Tariq, before I conclude to you, thanks a lot. I thank my esteemed speaker for sharing their experiences with us, for their time. And thank you a lot for the very nice discussions. And thanks a lot for Ezisurg for this opportunity. Now we have new friends in Dr. Skorbich and Dr. Al-Masri. We've been friends for some time now, me and Mohammed. It's always great to meet with people like you. Dr. Tariq, Mr. Tariq, the microphone is back to you. Are you there? Or Alex?
You left.
Well, if they left, I think there's nothing else for us to do anymore. It's a weekend here in Abu Dhabi. Actually, it's an extended weekend. Friday and Saturday are the holiday here, and today is an Islamic holiday, so we have 3 days. Thanks a lot for your time. Enjoy the holiday, the extended or the standard one, and I hope to meet with you in person, everybody, as soon as possible. Thanks a lot, gentlemen. Have a good day.
Thank you. Thank you, Dr.
Bye.
Safwan. Thank you, everybody.
Bye.
Bye.
Bye.